Yo, of course, is known to many of you. She's a trainer and consultant across the public sector with a particular interest primarily in adult social care and autism and the law. She was a member of this NAP, Autistic Advisory Panel that I mentioned earlier. She's now the strategic lead for the National Autistic Taskforce, and she led the development of the NAT Independent Guide, which is what she's going to be talking about. She writes on legal and policy matters affecting autistic people, and her book, Social Work with Autistic People, was published last year. Yo, over to you.
Thanks very much, Ian. I do have some slides, so I will make those visible to everyone now. So I'm going to shift our focus a little, if I may, at this point, more towards practice in health and social care, which is more my field. I will start just by going back over some of the things to which Sarah has already alluded, and Ian mentioned NAT's origins. So NAT has been around now for 3 years. NAT is autistic run, as Ian introduced himself as our token entity, and NAT draws very much on collective autistic knowledge and expertise, but NAT is a specialist organisation. It is not intended to be generally representative of autistic people. NAT's focus is very much on providing a stronger autistic voice on issues of relevance to a group that I loosely coined the term the other half for. How do we define the other half? Well, we're talking about autistic people who may be less able to advocate for themselves. Autistic people who are diagnosed with learning disabilities, who are considered to have the behaviour which challenges, autistic people who are less verbal, and autistic people described as having complex needs. So our focus is very much on issues of relevance to that group, and I'm highlighting that to try to ensure that nobody gets the impression, as we talk about the NAT guide, that this is simply a guide to how to help and support autistic people who are able to advocate for themselves. Very much not the case. It's very much about supporting autistic people right across the spectrum. Those involved in NAT, as Ian says, were drawn from those originally recruited by Diana Murray to the National Autism Project, and have particular knowledge and skills in care and support and relevant other knowledge. So the directors of NAT are myself, Lene Buckle, Damien Milton, and KB Brooke. We also have others involved who are assisting us, such as Ian Reagan, Joe Minchin, and others. I also just want to set what I'm going to say in a little bit of context, because as Ian said, the NAT Forum has been quite a long time in the coming, and it is actually a little while since we originally published the guide. And now we have quite a lot of developments going on in English. In England, we have the refreshed Autism Strategy and Implementation Plan. Some of you may have heard me on the subject of the Autism Strategy before and know that I am serially not hugely impressed by it, but nevertheless, there are some things, mainly in the implementation plan, which we do welcome, in particular the extension of LEADER to autistic people without learning disabilities, and the expansion of the Stomp and Stamp campaigns, as well as the improved digital flags to identify autistic people, which will, amongst other things, lead to better data collection around mortality and health inequalities. I'm sure many of you who work in the field are also very aware that recently the government made an enormous announcement about social care. However, if you actually read the fine print, we will see that there is little or nothing that actually suggests that frontline social care is going to get any more funding anytime soon, and certainly not nearly enough funding for local authorities to be able to adequately meet the needs of their autistic populations. In Scotland, we have proposals for a learning disability, autism and neurodiversity bill and a commissioner, all very welcome. I admit to a certain amount of skepticism. We await to see what actual outcomes that has in terms of meaningful impact on the lives of autistic people. And of course, we also have the proposal to develop a national care service for Scotland. Again, insufficient detail to really have a view on that as yet. We await developments. But I think in the context that we do actually currently have now, the NAT guide is still extremely relevant. What is it? Well, it came about in part because I've been involved in providing specialist autism training in addition to my legal work with social workers for quite some years now. And all too often, practitioners enthusiastically learn all about autism, and then they say to me, but where can I get a good service for the autistic person who I am assessing who needs care and support? And what would that good care and support look like? So the NAT guide is our attempt to give them an answer. It was originally published back in 2019, but obviously COVID has made it quite difficult to distribute the guide as effectively as we would have liked. It's very much intended for care providers, but also for care commissioners and care inspectorates, who we would strongly encourage to use it to hold providers to account for the quality of care that they are providing for autistic people. It's about what good care and support looks like for autistic people right across the spectrum and in all age groups, so children as well as adults. The other key thing to recognise about the NAT guide is not only is it a guide that was written by autistic people, but it has been created entirely independently of those who commission, provide and inspect health and social care. So what does the guide offer to care providers, care commissioners and inspectorates? Well, it sets out what we consider the 10 key elements of quality care. And it relates these directly to the health and social care standards used by care inspectorates across all 4 nations of the UK. It provides a really detailed and autism-specific view of what good care looks like. It's also intended to empower those who use services, who are supported by care and support services, to evaluate for themselves the quality of the care they receive. And we have an autism-specific easy read version available on the NAT website that was created on behalf of NAT by Opening Minds. It's also for care providers, schools, health services who wish to adopt it, a way for them to demonstrate the quality of their provision. And it's also intended to empower care commissioners to identify whether the service that they are being sold as specialist for autistic people really has the quality that they are being asked to pay for. So without further ado, I'm going to talk through a little bit each of the recommendations in the guide and just talk a little about what they mean and how perhaps they might be realised in practice, which is what I hope in another half an hour or so you will all be discussing in the workshops. So top of the list, and the numbering is not coincidental here, we have respect and promote autonomy. This is the top priority. And yes, we do mean for autistic people right across the spectrum. Very much we mean for the other half. Because the best way to provide the absolute best care and support for people, the best way to safeguard autistic people, is to enable us to have as much control over our own lives as possible. So we're not talking about just being person-centered. We're not talking about putting I statements into people's mouths. We're not talking about minor choices about what you'd like to do this afternoon. We're talking about real control and influence over who supports us and what they do and what we do with our time, our lives, where we live, who we live with, all of these things. And we are highlighting the fact that all too often in care and support services, the mental capacity of autistic people is assessed, and people assume that capacity is a fixed characteristic caused by the disorder, instead of recognizing that most disabled children and young people grow up wrapped up in a certain amount of cotton wool, lacking experiences and opportunities to practice decision-making and risk-taking and to learn skills. So good care and support actually seeks to increase people's mental capacity to take their own decisions, to support their learning and practicing at making decisions. Good care and support also distinguishes between autonomy and independence, because they're two different things, and sometimes they can be in conflict. Independence is, of course, a very high priority for all local authorities who are desperately trying to make their very stretched budgets reach as many people as possible and trying to reduce their care and support needs. So making people more independent saves money, great, unless it makes them less autonomous. Because if someone has a lifelong permanent disability and they need support, and they're always going to need support, there can be dangers in maximising independence when it reaches a point where maximising independence actually means that that person has to cope with a lot of stress, expend what limited resources they have on day-to-day survival, and actually that reduces how much control they can have over their own lives. Reasonable adjustments need to be made much better to enable decision-making. Those of you who are familiar with the Mental Capacity Act will know that we're supposed to take all practicable steps to support people with their decision-making. But practitioners can often trot out the examples given in the Mental Capacity Code of Practice, like pick the right time of day, but don't know the most basic thing about supporting autistic decision-making. Give us time to process the information. And preferably present the information in accessible forms using visual as well as oral communication. Respect autistic people's right to make unwise decisions. We may have different priorities. Conforming, being included, doing what's typical may not be a big deal to some of us. Our priorities may be different. What looks to other people unwise might be the right decision for us. And we need to prioritize people's human rights and have a rights-based approach to care. We need to ensure that people, whatever their mental capacity, are given full and honest information about their own lives. We need to teach care workers that lying to people is not acceptable. And we need to regularly review and question restrictions. Why exactly is this restriction necessary? Do we actually have an evidence base for assuming that this autistic person will come to harm? Have we attempted to teach them to keep themselves safe, or have we just gone, there's a risk, so we need to restrict this person? And finally, we need to make sure that staff actually follow people's care plans in practice, because you can write the most wonderful person-centered care plan, but if the care workers are too poorly paid, too rushed, and not able to read and implement the care plan in practice, then it's just a piece of paper. So that's what we mean by respect and promote autonomy. We also think that good care and support supports communication effectively throughout the lifespan. So we think that services should routinely offer and be receptive to alternative forms of communication. And we mean that with autistic people right across the spectrum, including those of us who speak. People need to have up-to-date technology and internet access. There is a considerable delay and deficit in prioritizing high-speed internet connections and up-to-date technology for those who are very dependent on care services, who live in supported living, residential care, and so on. We highlight the benefits of care services having a specialist role of a communication support worker, an idea initially floated by Dinah Murray, and the value of a specialist focusing on exploring and developing individual communication systems and development of functional communication at all ages, never ever assuming that an autistic person is incapable of functional communication. And we think that it's important for care providers to support and empower staff to share, learn, and develop communication knowledge and skills. In the guide, we illustrate our recommendations with many case studies. And in the area of communication, we have a particularly important case study, I think, from Surrey and Borders Partnership NHS Trust and their augmentative and assistive communication project. And I believe we have Katie Nurse here from that project, if people would like to speak to her. She is the full-time project lead, and the project focused on service users who are autistic and have moderate to severe learning disabilities. Most have lived in large hospital institutions for many, many years. And the focus of the project is to work on making information accessible to all of those people, including those with needs considered complex. So that's about finding what works for the person, not assuming that the person is incapable. It started with just one person, but now involves 25 people. And the aim is to not just build a communication system for someone and then move on, but to embed the use of individualized communication in daily lives and in the routine practice of staff, in order to enable people to communicate their choices, their dreams, their desires. That requires ongoing support to review and adjust these things to meet people's needs, and it requires an openness to using a very wide range of approaches to communication to suit the individual, from high-tech options to quite low-tech ones. The third recommendation of the guide is to provide care which is autistic person-centered. Autistic person-centered is a little bit different from just person-centered care, because what we mean is focusing on identifying and recognizing the autonomy of the autistic person themselves as distinct from the views of their families, care providers, and care commissioners, which doesn't mean that the views of their family are not important, but they are separate. It means considering the needs of autistic people in the planning and management of the service, minimizing staff change, matching staff to service users on the basis of mutual interests and compatibility. It means thinking about what the goals of care and support are, focusing on maximizing well-being and reducing distress, rather than giving people a normal life, or teaching them to stop displaying their distress in ways that challenge other people, rather than addressing its causes. And it means a care and support service which routinely considers autistic needs, such as preparation for change, options to withdraw from social interaction. I know we're short of time, so I shall move fairly quickly through the recommendations. Number 4, tackle environmental and other stressors. So we think every care and support service, every environment that autistic people are receiving care in should have autistic-led sensory reviews of this environment. If at all possible, the individuals who use the service should be invited to feedback about what is a problem sensory-wise, what they need in the environment. If that really is not possible, then the next best thing is other autistic people. Sensory adaptations, protective equipment like sunglasses, noise-cancelling headphones should be routinely available. Staff policies should prioritise autistic needs. So, for example, banning perfumes and fragrance deodorants amongst staff. Ensuring that staff respect sensory preferences, including people preferring not to be touched or liking a particular kind of touch. And providing safe ways to meet sensory stimulation needs as a matter of course. Services prioritising accurate, honest and specific information being provided for service users. Prioritising autistic people's need for routine, structure and predictability, even if sometimes staff might find it a bit boring. And ensuring that there is always good preparation for change, including supporting autistic people to understand potential changes in advance and developing the ability of autistic people to understand and access information about what will change. Recommendation 5 is around removing barriers to access. Things that would make a difference there, ensuring that people have ready access to advocacy, ensuring that people are fully involved in decision making. So even where someone lacks mental capacity, they should still be fully involved in best interest decisions about their lives. It's also vitally important around health care and health inequalities, ensuring that there is good and early recognition of co-occurring conditions and that care and support services eliminate barriers to healthcare, ensuring that people have good and familiar support with accessing health care appointments and that health providers make reasonable adjustments. It's also important that care and support staff are trained to support decision making and to support access to healthcare, and that they challenge discrimination in the treatment of autistic people across all services. Facilitating access for autistic people to the full rights of citizenship, including voting and political activism, including connecting with the wider autistic community. Ensuring rewarding activities for people, that people have a right to do things which are meaningful, not merely be kept busy. Enable people to contribute to society in a way that is meaningful to them. So just a very quick example of that from my direct experience, my younger son, who is autistic and has learning disabilities, has a lifelong and passionate interest in steam trains. So why am I the only person? No school, no care service has ever suggested that he might volunteer for a steam railway. It fell to me to suggest that fairly obvious way for him to participate in the world in a way meaningful to him. His school runs a career day full of care providers and day services. Yeah, so meaningful activity in ways that actually matter to the person, not just keeping people busy. And again, ensuring equality in internet technologies and up-to-date devices. Number 6 is around fighting the stigma and discrimination. So we'd like people to create and sustain a rights-based approach to care, to actively support the rights of autistic people, to recognise that no autistic person requires long-term institutional care for autism or learning disability. Yet again, just last week, we had all over the news the Safeguarding Adults review from Causton Park. And yet again, we had the same talking heads saying, yes, 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 we must do better at getting autistic people and people with learning disabilities out of hospital. But there will always be autistic people and people with learning disabilities who need specialist help. Rubbish. Not in institutions, they don't. Not unless they have an acute mental illness which requires treatment. This assumption is built into the system and it's really, really prevalent. Specialist, complex. These are just labels, they don't mean anything. CQC just reported in Out of Sight, Who Cares, that those very complex people who are in institutions are actually receiving degrading and inhumane care involving restraint, inappropriate medication, and being cared for day to day by unqualified healthcare assistants on the minimum wage with little or no autism training. This is not specialist help. Real, effective, and measurable progress towards all autistic people living in the community, not just another target, not just another program. We need to stop putting people into institutions and meet their needs in the community. And that comes from not talking about behaviours, not saying people are complex, just providing good care and support in the community. Supporting staff and families, reassuring them to have the legal literacy and the confidence to enable and empower positive risk-taking. And a positive and accepting attitude towards autistic identity, which also tackles bullying. And finally, a key element in there is tackling and discouraging those fixed beliefs and assumptions about capabilities. Oh, they're not capable of that. They have behaviours, they have complex needs, and these sorts of things. Recognising behaviour as distress is such a key recommendation that I could easily talk about it all day, but I only have about 10 minutes. And I've got 3 more recommendations to get through. So very quickly, we do not think that autistic people should be being restrained at all. If a restraint does happen, that should be treated as a failure. And the service should be going, what did we do wrong that we allowed the situation to deteriorate to such an extent that we had to subject this person to inhumane treatment like that? Stop blaming autism. Autism does not cause challenging behaviours. This is not an inevitable consequence of autism. People would not say that they had behaviours or their friends or family members had behaviours. But the minute someone's autistic, we have behaviours. Rubbish. We need to stop doing this. Quit labelling people as complex. An autistic colleague of mine, who is less familiar with social care than I am, was going with me to a meeting a few years ago in relation to the National Autism Project. Now, this friend knows a lot about medical diagnoses. And she said to me, what does this word complex mean? I keep hearing people talking about complex. That's not a medical diagnosis. What's complex mean? Expensive, I told her. It doesn't actually mean anything in terms of the person and their needs. Do not take away choice and control for an autistic person. When an autistic person is distressed, the system puts in more people, more interaction, staring at them all the time, and putting them into even less suitable environments. Give people more choice and control to be able to cope with the world that they are experiencing. Challenge proposals or decisions to remove an autistic person from their local community. Do not accept this person cannot be cared for in the community. Modify the environment to meet the needs. Look for underlying causes, not just triggers of behaviour. Very often I see people doing a type of analysis that looks to me like looking very closely and minutely at the last straw when the camel's back breaks, when often we may be experiencing cumulative stresses which have built up. Work with the autistic person as a collaborator to make sense of what is distressing them and help them. Support us to manage stress and to recover from distress. Avoid focusing on behaviour support rather than meeting people's needs. And recognise the difference between behaviour which is actually a problem that interferes with someone else's human rights or is seriously harmful or dangerous, as opposed to just not normal. Accept and accommodate autistic behaviours that are just not normal and aren't infringing other people's rights. Support autistic people to find ways to meet our needs, provide opportunities to meet our sensory needs, and recognise that sometimes it's the service or the staff or the environment which is just not suitable for this autistic person. And we need to change the service or the environment. Again, we have a case study around recognising behaviour as distress. We don't have time to talk about it in detail. It's about St Clement's School in Scotland, who instituted a no restraint policy very successfully. So please do have a look at that example in the guide for how it, yes, really can be done in the real world. Recommendation 8 is around better transitions. A whole life approach, not just transition from children to adult services, but from one placement to another. Plan well in advance for transitions whenever possible. Advocate for good advance planning from service commissioners. Tell people what's happening. Warn them about moves. Yes, it may upset us. We're autistic. We don't like change very much. But it's a lot better to be warned about it than it is to have people spring surprises. Prepare autistic people. Provide information, support, repetition, visual aids, timetables, and don't expect us to be terribly happy about it. Recognise that uncertainty and unpredictability cause stress. Recommendation 9 is about training. All care and support services will say that they do autism training, but is it regular, sufficiently advanced, really practical training? Awareness is not enough. Does it support staff well enough? Is the training autistic-led and or autistic designed, preferably both? Does the training include ensuring that staff have a good understanding of human rights and mental capacity law? Is there ongoing support and development for staff focused on people's human rights? And does that staff training promote empathy for autistic perspectives? Or does it just teach staff about this strange breed of people? And finally, we think that good care and support services need to accept difference and support positive autistic identity. That's about recognising and referring people for diagnosis. It's about avoiding imposing ideas of what is normal. Accepting people's choices to withdraw from social interaction. Recognise that for autistic people, being included in every coffee morning and chat and other activity that's going on may not actually be good for us at all. Accept the fact that we may prefer things to stay the same, and recognise the difference between us making choices like this and being unable to cope with the change and needing support to do so. And also facilitate access for all autistic people right across the spectrum to opportunities to access autistic controlled space and the wider autistic community. So the NAT guide is, we hope, fairly comprehensive. It provides case studies demonstrating how many of the recommendations can indeed be implemented in practice. We do recognise that for many health care and care services, the recommendations are challenging when compared against current practice. And yes, we also recognise that some recommendations cannot be fully implemented without system-wide change, without considerably more investment, for starters, in social care. But there are things that we can do. Yes, there is a significant shift involved for many services from their current practices and some costs, although we would argue that system-wide implementing these recommendations would be massively cost-effective because it would prevent the massive bills for people being in ATUs. We also think that a lot of it is things that can be done without a huge amount of resources. It's about moving towards a genuine empathy with autistic perspectives, empowering service users, and also empowering frontline staff, enabling them to develop their skills and to engage in reflective practice. And finally, the carrot for care services here is that it will enable services to demonstrate the quality of the support they offer and persuade commissioners to fund them at an appropriate level to provide and maintain that level of support and good practice. So it's time for everybody to go off into their breakout rooms, where you will have the opportunity to discuss a selection of the recommendations in each of the workshops, and particularly how they might be implemented in practice in the context in which you work.